This episode is sponsored by our global research partners. Want to contribute to the advancement of medicine? Make some easy money while sharing your thoughts with market research surveys. Learn more and sign up using the special TFOC link on our website and in the description box below. Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy! Welcome to another episode of The Fellow on Call, the HEMONC podcast. We're coming at you from Merlot University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And today's discussion, we're once again continuing on our ongoing AML induction therapy series of episodes. Guys, there's just been so much information, but so much high yield information in the last couple of episodes, and I'm excited to move to the third part of this discussion. So much of this is super high yield as I'm studying for boards. My exams are in about a month or so, and I can say that the things that we've already discussed have already come up in question banks over and over, questions that came up in the ITE, so super high yield.
Yeah, I also think it's really important for anyone practicing out there. I mean, we really outline why we do what we do and really show you all the data. So remember to check out our website because we have links to all of this stuff in there. And today I'm really excited to round out this episode and get into things like, why do we do the regimen called FLAG? What's the rationale behind that? So really excited to get into it.
And sort of similar to, in our sickle cell disease series, AML was one of these things that was the same for decades. And all of a sudden, now there's a bunch of new stuff that we're doing. So interesting to talk about and can't wait to keep going.
All right, guys. So without further ado, let's roll that show.
All right. So you all know that I am obsessed with fall, as we discussed last week. What is your favorite or one anticipated fall decorating item? Personally, I'm a sucker for gourds. You'll come to my house. There will be gourds everywhere on every surface of all different shapes and sizes.
We always do a little bit of pumpkins outside. We get that going. And usually we leave it out for far too long and the pumpkins start to rot. But, nobody really pays attention to that. We just dump it in the trash can eventually. But definitely getting those pumpkins
The
up.
squirrels love you, I'm sure.
That's right.
Yeah.
I love pumpkins as well. I also really like scarecrows. And then honestly, I just like fall scented candles. I think that they're like super warm, super homey. I know it's not really a true decoration,
You would,
but
Ronak.
I am who I am. I'm not ashamed of it. It just creates the right sort of mood and environment at home. So big fan. And in situations where I can't use candles, finding scented air fresheners like for my office and things like that is a great workaround.
Those like cinnamon brushes I sell in the store.
Highly recommend if you haven't checked them out.
To be fair, I do love those nice candle smells because Christine's really good at choosing that. She's always like, smell this candle. And I'm like, I really don't want to. Let's just move on. But honestly, those candles are amazing. It really sets the tone, It feels like fall.
Can I just point out that I basically said that and Vivek gave me grief and then he went back and said the exact same thing. So,
You're right.
Again,
You're right.
Listeners, you guys can make of that what you will. I think we have our answer. Vivek is also a fall-loving individual.
We were talking about this case in the past couple of weeks with our patient, a gentleman who had AML. I want to change the case up just a little bit. Let's say we have a patient with AML, and this time cytogenetic testing showed a translocation 821. So that's consistent with favorable risk disease. Molecular testing, otherwise unremarkable. And, last week we talked a little bit about this 7-3 plus gemtuzumab osigomycin, or GO. Where did that treatment come from? What's the evidence behind that?
So myeloblasts actually express CD33. So an antibody drug conjugate was developed targeting CD33 with a chemotherapy payload of osigomycin. So this drug, as Dan mentioned, is called gemtuzumab osigomycin, or the brand name is Mylotarg. And actually, originally, this drug was given as a single megadose of 9 mg per meter squared, and ultimately was actually taken off the market because it led to a complication called VOD or SOS, or veno-occlusive disease of the liver. And this would result in liver failure. And there were subsequent studies looking at a fractionated dose at 3 mg per meter squared given every 3 days for 3 doses. One of the pivotal randomized phase 3 trials was called the Alpha 0701 study that was published in The Lancet in 2012. And in this study, patients with AML were randomized to 7+3 versus 7+3 plus GO, regardless of cytogenetic risk. The fractionated dosing of GO was tolerable and led initially to improve EFS and OS at the interim analysis, and longer-term analyses thereafter showed no difference in EFS or OS, so this was not really adopted as a standard of care. Then, fast forward to 2014, and there was a pooled trial-level meta-analysis of multiple studies looking at this 7+3 plus GEO regimen compared to 7+3. And what they found was that each study included slightly different dosing strategies, but overall there was limited heterogeneity. Generally, GEO was given on day 1, 4, and 7 of the induction therapy portion of treatment, and in this study, outcomes were stratified by ELN risk stratification based on what we talked about in our previous episode of favorable, intermediate, or adverse. And what this study actually showed was significant benefit for favorable risk patients when they received 7+3 plus GEO, but not really any major differences when it came to the intermediate or adverse risk groups. The 5-year overall survival estimate was 78% versus 55% for those that got 7+3 plus GEO compared to 7+3 in that favorable risk group setting. So because of this analysis, we now use 7+3 plus GEO as a standard of care at many centers for patients with favorable risk disease. Really, really cool, fascinating history lesson there too. A drug previously taken off the market, we sort of reevaluated its utility, and now it's become part of our standard of care. Really, really cool concept.
Yeah, and one of the things I wanted to point out with this, some of the terms that you'll hear associated with favorable risk AML is something called core binding factor AML. And for the longest time, I wondered, what the heck is core binding factor AML? What does this mean? And really what's happening is that there's a core binding factor complex that binds to a gene called RUNX1, RUNX1. And when you have a mutation in this core binding factor complex of core binding factor and this RUNX1, RUNX1, when you have a mutation there, you block differentiation. So normal functioning of this complex is to allow for differentiation from a myeloblast onwards to a normal cell. And now you have this block in differentiation. And it just so happens to be that the mutations associated with this are inversion 16 and translocation 821. Each of those cytogenetic changes affect a different part of this core binding factor complex. But again, the idea is this is the driver of the block in differentiation. The other thing I want to point out for favorable risk AML, when you look at the European Leukemia Network risk stratification, which again, we'll link to our show notes, you'll notice there's caveats here. And for favorable risk patients, even if they have a high-risk molecular mutation, there's actually a thought that they still should be treated as if they're favorable risk. There's a lot of controversy whether you should follow that or not, whether that high-risk mutation should trump that. Obviously, if you have something like a TP53 mutation, that would trump it. This is where the nuance comes in. This is where tumor board discussions are important. And this also shows you that this is going to change. This is going to evolve as we incorporate more molecular characteristics. Early on for risk stratification, really what we relied on were cytogenetics, these larger chromosomal rearrangements, because that was what was commercially done. That was easy to do. That was easy to study. And now we have these new molecular mutations. So how do we sort all of this out? And one of the classic things you'll hear is if you have core binding factor leukemia, but then you also have a c-KIT mutation, then that portends actually a poor prognosis. And interestingly now, instead of thinking about all of that nonsense, what we do is what we call MRD testing. We can actually look to see if we have very low levels of MRD. If you're MRD negative, that patient's fine. They should be treated as favorable risk. They don't need an allotransplant. If they're MRD positive, move them to intermediate adverse risk. So that kind of makes it a little bit easier. But I just wanted to point that out as a little bit of nuance for these favorable risk patients. So we'll get more into the MRD testing considerations in a later episode, but let's change the case again. So we, again, remember previous episodes, we talked about this whole 7+3 backbone and all that stuff. One of the things we talked about is we wanted to know if they're favorable risk. The other thing that we talked about, we said we want to know if they had an antecedent MDS or MDS-related changes or potentially an antecedent MPN, another myeloproliferative neoplasm that evolved into AML. So let's say, what if our patient did have what we call MDS/AML? Remember, we talked about that in one of our earlier intro episodes, or in other words, AML with myelodysplasia-related changes. How do we treat those patients?
Definitely check back to our intro episode to understand a little bit more of what we're looking for to make that diagnosis. But remember that really this means that we see that characteristic cytogenetic abnormality or series of abnormalities associated with an antecedent MDS or molecular mutation associated with MDS in a patient who's been diagnosed with AML. It is a different animal when it comes to AML. These diseases, they've been sort of brewing in there for a longer period of time. The idea is that maybe they've accumulated a greater range of mutations that just makes them a little bit tougher to treat and a little bit harder to clear out. This gets to a drug called CPX-351, also known as Vyxeos. And when I first heard about this drug, the sort of pharmaceutical cynic in me just thought this must have come from a board meeting where they were all sitting around and saying, how can we make 7+3 more expensive? And it's basically what it is it's a liposomal version of 7 and 3. So it's 7 and 3 packaged together in a specific molar ratio that was found to be ideal to kill cancer cells in vitro. In the lab, they said this molar ratio of 7 and 3 seems to be the most effective. So can we ensure that that's what's delivered to the cells by packaging it together in a liposome and make a little scratch on the side? I evolved my position on this. I actually do think there's value based on some of the trials. In particular, they looked at Vyxeos versus 7+3 chemotherapy in patients with secondary AML. And so treatment-related AML or MDS-related AML. And that was defined for the purpose of the study as MDS-related AML based on cytogenetics or morphologic dysplasia, like we talked about in our intro episodes. Patients who developed AML from antecedent myeloproliferative neoplasm, like essential thrombocytosis, polycythemia vera, primary myelofibrosis, or patients with treatment-related AML, sort of associated with prior chemotherapy or radiation. This was a phase 3 trial. It got published in The Lancet back in 2018. They found that there was an improved rate of complete remission in patients treated with Vyxeos, 50% versus 33% in the control group, and also improved overall survival. One issue that did come up with Vyxeos and the safety profile is that it does tend to lead to very prolonged periods of cytopenia, sort of a prolonged period of count recovery. Of course, we can't just take a study at face value, right? We have to look at finer detail in how the study was put together, what sort of analyses were used. Vivek, can you talk a little bit about some of the details on how the study was designed?
There's a couple of things that are a little bit problematic with the study, but again, this is medicine, right? And it's important to critically appraise and think about how do we apply this to our patients. So the first thing is, at this time, we didn't have the definitions for myelodysplasia gene-related mutations. So this was all based on cytogenetics and morphologic dysplasia. Remember that in our current way that we diagnose patients with MDS-related AML or AML-MR, MDS/AML, whatever you want to call it, we use cytogenetics and we use molecular mutations. We don't use morphologic dysplasia criteria cutoffs. We had talked about what those would be in our previous episodes, but that's one little caveat for these patients, right? Did all of them truly have what we think about as MDS-related AML if they just had some dysplasia? Is that the same as when you have some of these higher risk mutations? The other thing that's really important to note is if we're talking about overall survival, what did these patients get if they had refractory disease? That's one question. And number two, what did they get in consolidation? That's phase 2, right? And so we want to do consolidation like we would for any other patient. The problem is for the control arm, what they got standard 7+3. And then if they failed to achieve a remission, they were only allowed to do 5+2. And nowadays, like Ronak mentioned in our previous episode, when you have overt disease, we switch to a venetoclax-based regimen, right? We switch to some of these more different salvage regimens. So that wasn't done. They weren't allowed to do that. They had to get 5+2. That's a big ding right there. Number two, in consolidation, what we do, standard of care, is to give high doses of cytarabine. And what these patients got in consolidation was 5+2 chemotherapy after remission. The Vyxeos arm just got more Vyxeos. Vyxeos is crazy expensive. Why did they design it like that? That is not standard of care for any patient that was being treated for AML in that era. So really what we found was that we're getting these patients treated with not standard of care treatments. So how can we apply this to our patient in front of us now? I think it still is promising. I still think it's very reasonable to give to patients who do have secondary AML or maybe MDS AML related AML. It's reasonable to consider this, but it's important to note those caveats. Is it that much better than 7+3? We don't really know that yet.
Let's take a moment to learn more about the sponsor for today's episode. Imagine there was a way you could use your expertise as a healthcare professional to contribute to medicine, to improve the patient experience, and help impact the development of new drugs and devices, all while making some extra money.
We have the solution. Market research surveys through our partners, M3 Global Research, All Global Circle, and M Panels. Through their easily accessible and secure platforms, you can complete market surveys on your own time. It's the perfect way to make some extra money while making a difference. It's so easy, and we couldn't recommend it more.
To learn more and to sign up, use the special TFOC link on our website, thefellowoncall.com, and in the description box below. Vivek, that was great. And I think the one other thing that I want to add that I've certainly learned from fellowship was also the fact that the patient population that was represented in that study was greater than the age of 65. And so even though the FDA indication is for a broader age group, we actually don't have data to support the use of that in patients before the age of 65. So just again, some things to kind of keep in the back of your mind. Different centers will do different things. Some places don't use Vyxeos at all. These are just some discussions to be made aware of as you're going about your leukemia educational journey. Another regimen that we did discuss briefly was this regimen called FLAG-IDA-VEN. You kind of alluded to this in passing. So what is this? When do we use this? And what are some of the data to support its use?
So this is where Vyxeos might honestly go away, is because of this regimen, FLAG-IDA-VEN, and the addition of venetoclax. So historically, the patients Dan described with secondary AML had very poor outcomes. Like he described, they had this disease brewing for probably a longer period of time, picked up more mutations. AML is quite heterogeneous, right? You don't just have one clone, you have a bunch of clones. It has a ton of mutations, right? It may be refractory to chemotherapy. They tended to have worse prognosis, more challenging patients to really maintain their remissions, even if we initially get there. So the MD Anderson group really has laid the foundation to using idarubicin. Ronak had talked about how it has 4 to 8 times the potency in vitro compared to daunorubicin, better CNS penetration. The thought was this is going to be a better drug. The 7+3i studies, like we talked about in our previous episode, didn't pan out, right? Had some excess toxicity, didn't really pan out for event-free survival or overall survival, the things we care about. But the MD Anderson group said, how can we improve upon using idarubicin? What else can we do? And this is where this FLAG-IDA regimen came from, and you add this pill called venetoclax. We'll talk a little bit about venetoclax in a bit, but I want to focus on the FLAG-IDA portion. So IDA makes sense. It's an anthracycline. We knew from 1973, the original 7+3 studies that we talked about previously, that the anthracycline was really important to killing these leukemia cells. So that's why the IDA's in there. So what about FLAG? What does this stand for? Interestingly, the G is GCSF. What you're doing with GCSF is you're priming the cells to go into S phase, because all of our therapies are going to attack S phase. That's one thing. And there's another neat trick that also is important for using that GCSF to prime our leukemia cells for death. And that comes in with the FL and the A. So FL stands for a drug called fludarabine. Fludarabine is one of the purine analog antimetabolites. So what does it do? How does it work? Well, this is why it works so well. It's not really the fludarabine is killing the cancer cells. That's not what we're really using fludarabine for. What we're doing is we're giving fludarabine 4 hours before we give a high dose of cytarabine. Cytarabine, or Ara-C is what it's called. It's a prodrug. It needs to be activated in the cell to an active compound in order to kill the cancer. There's an enzyme within the cell that does that. And so what we have now is the fludarabine. What it does is it upregulates the enzyme activity in the cell that's going to convert Ara-C, regular cytarabine, into its active form. So fludarabine is priming the cell. It's like upregulate that important enzyme that's going to convert all of the inactive cytarabines into active drugs so it'll optimally kill this cancer cell. So you basically give fludarabine 4 hours before, high dose of cytarabine, which will then enter the cell. More of it will be converted to its active form, and it has more optimal killing of the tumor cells. So it's really a neat design. The fludarabine's not really killing the myeloid cells. The fludarabine is telling all of the myeloid cells to upregulate the enzyme that's going to activate the cytarabine compound. And that's why it's given 4 hours before cytarabine. So this regimen, and the GCSF is priming it as well. It's also upregulating the enzyme. It's pushing everything into S phase so that this cancer cell will die. That's the whole point. So it's a very interesting, really smart regimen that was developed. And so why do we talk about this? So you have this FLAG-IDA, that's the rationale for that. The venetoclax, this is basically a small molecule inhibitor of something called BCL2. BCL2 is anti-apoptotic. So this basically pushes these cells to apoptosis. It causes them to die, essentially, because myeloblasts survive by upregulating anti-apoptotic BCL2. So you block that, now it undergoes apoptosis, right? Makes sense. So this FLAG-IDA ven, why is it good for high risk? Why do I think maybe you should be thinking about this in these high-risk MDS-related AML, secondary AMLs? There were multiple studies done from the MD Anderson group, one's published in JCO and more recent ASH abstracts, that show the CR rates are phenomenal, truly phenomenal in the adverse risk populations with FLAG-IDA ven. So where should we use this? We should really consider using this for our high-risk patients. The problem is single-center study. We need a randomized study to know if FLAG-IDA ven is better than 7+3. That is standard of care for many centers. It did come from MD Anderson. There are other things involving cladribine instead of fludarabine. Same concept, though, that you're upregulating the enzyme in the cell that converts the inactive Ara-C cytarabine to its an active drug form that kills the cell. So it's a genius design. And you're pushing everything into S phase so it'll die optimally. Those are the types of regimens that you'll see. And I think that it's reasonable to consider those instead of Vyxeos. And we'll link some of that data in our show notes.
In our last episode, when we were talking about variant allele frequencies, we also mentioned this FLT3 mutation. And I think, people have probably heard about this. It was certainly one of the first AML-associated mutations that I learned about back in residency. So what is the significance of this in brief terms, and how does it change how we end up treating them? I understand it's poor prognostic risk factor, generally speaking, but what do we do when we see that FLT3 mutation?
So the wonderful thing about what we have now is we have small molecule inhibitors. We have these tyrosine kinase oral drugs that will target. It's like sniper rifles. The way you talk about to patients, you say you've got a sniper team coming in to snipe out all of those leukemic blasts. We're dropping an atomic bomb with chemotherapy, but now we're going to snipe out these residual, maybe chemo-refractory FLT3 mutated clones, and we can snipe them out with these medications. The older medication used was sorafenib. It was a tyrosine kinase inhibitor that had a bunch of effects on multiple areas and didn't work out super well. And then we developed this drug called midostaurin. And there was a randomized study called RATIFY, which included patients who had a FLT3 ITD or FLT3 TKD mutation. Those are just different types of mutations. We're not going to get into the full nuances of that, but in general, the ITD mutated patients, we think, respond more to these small molecule inhibitors. And we randomized patients to 7+3 chemotherapy plus midostaurin versus 7+3 chemotherapy plus placebo. This is why we're getting that FLT3 testing upfront. We want to know because it can change our initial treatment plan. Outcomes of that study, there was an improved overall survival. If you look at the median overall survivals, it's insane. The median overall survival improved in the group with midostaurin at 58 months versus about 28 months in those who did not receive midostaurin at placebo. Now we're going to talk a little bit about critical appraisal. Why is that a problem? What's the issue with that? Medians are not perfect. Actually, what happened was that these FLT3 positive patients hovered just above the median when the tail kind of tapered off. So it exaggerates actually their actual response. If you look at the absolute differences, it's maybe like 5 to 10% difference, absolute percentage differences long term. So that's why medians can be deceiving. It's still an improvement though. It's still an important improvement. Inclusion criteria for that study uses something called allelic ratios. Remember, we use variant allele frequencies now. We don't really use that anymore. Nowadays, if you've got a FLT3 ITD mutation, or you have a FLT3 TKD mutation, we talked about how 10% is a reasonable cutoff. Even if it's less than 10%, you do it. Because the concern is that's going to be your relapse. That clone is going to be the one that lives through the chemotherapy, that evolves more, and you want to snipe it out now with the targeted pill that you have. It also gives you something to chase. You can look at MRD testing looking at FLT3, and that's highly prognostic. It can really help you risk stratify some of these patients. So that's why that can help. There was another trial, so that was done in 2015. That was actually the first study that changed 7 and 3 from 1973 onward, really, other than the dosing changes of the daunorubicin we talked about. There was another study for another drug called quizartinib, only approved for FLT3 ITD patients. It's a study called Quantum First. It was done after this study, this RATIFY study with midostaurin. It's not that it's any better or any worse. You can use either one. So that was just published later. We'll link it to our show notes. In our expert discussion episode, we can talk a little bit more about the nuances of that, but just know that both are options, 7+3 plus midostaurin or 7+3 plus quizartinib. And at the end of the day, there's no real major difference between those two, so dealer's choice, whatever you're more comfortable with.
What an absolute whirlwind. And I think the theme of this episode turned out to be, we had 7+3 as this standard of care for literally 50 years. And in the beginning of the episode, we talked about how in our favorable risk patients, we can add things like GO onto their regimen, which resulted in pretty impressive changes in terms of outcomes. And then on the other end of the spectrum, we have our patients with unfavorable disease, that higher risk disease. And now we have options for them too, including the addition of things like 3 inhibitors for patients that harbor those mutations, or even considering alternative regimens like flag-ida-ven or Vyxeos for the treatment of these patients. So what's truly impressive, yes, we are certainly seeing differences in terms of outcomes with the addition of these. I still think that the history lesson of hearing about how 7+3 has stood the test of time is still really cool. But who knows how the future of AML treatment is going to change in the future. Guys, any other final thoughts that you all have?
No, I think that was a good summary. A lot of things on the horizon for this disease. And I'm just so happy that we're finally making some progress after, like you said, 50 years of messing around with 7+3.
All I have to say is check out our show notes, check out the website. We're really going to detail all the things we talked about. It's hard to understand in audio format. Listen to it a couple times, but really check out the show notes.
All right, guys. Well, that wraps up a fantastic discussion, a 3-part discussion on AML induction therapy. So until next time, we'll see you all later.
See you later.
Peace.